So when we're looking at our cues, and we're going to prioritize, okay? Number one, altered urinary elimination. Okay, so if you have someone in the clinical setting and you're doing your assessment packet and you know that they have urinary incontinence, you need to make sure that you are addressing that altered urinary elimination, and then also include a tissue integrity, okay? Because they're at risk of tissue breakdown, they're at risk of infection. And then as part of your planning, okay, what are the things that you're going to do to take action? Okay, there are surgical and non-surgical things that we need to consider in order to treat urinary incontinence. Okay, typically we always want to do the non-invasive things first. Okay, the non-surgical things first. Okay, number one being nutrition therapy. What are some things that should be included in the nutritional therapy or the teaching of patients with urinary incontinence?
Try not to drink late at night.
Try not to drink late at night? Yes. Okay. We usually say nothing after 8 o'clock. Okay. Why? No caffeine, no alcohol, those irritant things after 8.
Disrupt their sleep.
Yeah, it'll disrupt their sleep. Remember, a lot of our alcohol, okay, does what? It acts as a diuretic. Okay. Can release those muscles even more for incontinence. What else as far as nutrition?
If they're obese, weight loss.
If they're obese, weight loss, excellent. Okay, and I think that's one of the first interventions that your book lists, is it? Okay. So caffeine, foods that are high in acid can also be very irritating. Drug therapy. So there's all different types of drugs, okay? Detrol, D-E-T-R-O-L. Ditropan, D-I-T-R-O-P-A-N. Vesicare, V-E-S-I-C-A-R, are some common anticholinergics. For men, we can see two common medications. Flomax, which is used for BPH when a man has an enlarged prostate, but that can also contribute to incontinence. So Flomax, and Cardura, C-A-R-D-U-R-A. And then for women, sometimes they will also use a topical estrogen cream. Okay. Then we have devices. Okay. And those devices we talked about were the incontinent pads. Okay. The Depends, the Always pads, those types of things. Now, the next 5 things, we start with diet, medication, appliances or devices, and then these are additional treatments, okay? Electrical stimulation, okay? There is a clinic in Columbia that specializes in urinary incontinence, and they do electrical stimulation to the bladder to help kind of restart those nerves to say, okay, we need to wake up and this is what our job is, okay? There's magnetic resonance therapy, pelvic muscle therapy, which is Kegel exercises, okay, bearing down, vaginal comb therapy, okay. With vaginal comb therapy, there are a series of cones that are inserted into the vagina, in which the woman holds that cone in place, learning to tighten those muscles, tighten the pelvic floor muscles, in hopes of strengthening the muscles to be able to control the bladder better. Okay, and then what kind of behavioral interventions can you think of? What kind of behavioral interventions would a person?
Would that have anything to do with smoking? Or not
Could.
really behavior?
But more, what are things to promote kind of a healthy, happy bladder? Bladder training. Okay, so those 2Q-hour voidings. Okay, making sure that we're meeting our fluid demand. Okay, and how much liquid should we consume in a day? How much water? Okay, about 2 to 3 liters. Okay, so we need to make sure, what are we drinking per day? Okay, are we drinking 2 to 3 liters of Mountain Dew? Are we drinking 2 to 3 liters of water in that big jug? Okay. Are we drinking iced tea, sweetened iced tea in large quantities? Are we drinking gallons of that per day? Okay. And then we have to address all of the over-the-counter kind of herbal alternative medicine type things that are out there. Okay? Because we have a lot of patients who will take cranberry tablets, or they drink a lot of cranberry juice because they believe that that helps with their kidney or renal health. And we know that what we put in our body, depending on if it's an acid or a base, it can change the pH of our urine. But there's not a whole lot of true evidence-based practice behind the cranberry tablets and the cranberry juice. Okay, but you will see a lot of patients that come in and say, oh, I drink this herbal tea, or I take cranberry tablets every day. Okay, and then the surgical management, there's a list in your book, but most commonly it's going to involve a type of surgical procedure where there's a sling where the bladder is lifted so that it's kind of cradled and not prolapsing and putting all of that extra pressure there. Okay? Looking for... the surgical procedures are on page 1334, okay? So you'll see a lot of sling procedures, and one that you can also see is where an artificial sphincter is created kind of around the original sphincter, okay, to help with closing and opening of the sphincter, okay? And then the final thing here is maintaining tissue integrity. And how are we going to do that? What would be important?
Mobilize the patient, assess the skin.
Skin assessment? Okay. How are we going to teach the patient to... Because ultimately we want our patients managing this, right? So what would we tell the patient, Rob?
To change linens, their bedding sheets.
Mm-hmm.
Also to get up and walk.
Mm-hmm.
and teach them how to check their skin.
Yeah, yeah.
Use a
So
mirror.
if they start to experience any burning or itching or notice any redness, okay, excoriation, okay, that they need to contact their physician, okay. But Rob said change their linens, okay. Well, changing that appliance, that device, okay. So their pad, their undergarment, whatever it is, because a lot of times people will try to wear them all day long, okay. And we can't encourage that, okay. But we have to encourage them, okay. If it is soiled, it needs to be discarded, and you need to put a new appliance or device on. Well, but it says it holds up to 8 hours, Miss Jennifer. Can't I wear it for 8 hours? No. When it's wet, when it's soiled, okay, you need to remove that, because what's happening? Even though it's wicking away, okay, we still got stagnant urine, and bacteria is going to develop. Okay, and bacteria can develop and go up into the urethra, and then that bacteria travels up and they get a UTI. Okay, so we want them to perform good peri-care, okay, with a mild soap, okay, and water. What are some other things? To maintain tissue integrity. Look at your books. What's there? What's it tell us to do?
Like, make sure their skin is dry, make sure they're dry their skin. And then, I would tell them, like, if they are experiencing that, probably, like, put, like, a skin barrier on it.
Excellent. Yeah. Okay. Don't we have skin barrier creams that can help protect the tissue? Okay. We want to do that. Okay. Now, we have to be very careful, because a lot of times patients want to use other different types of things that I call lotions and potions. Okay. Powders and all kinds of other things to help absorb moisture in those areas. Okay. Have to be very careful about what we're using, because some of those can then become very irritating to the tissue. So in the hospital, we know that we have different barrier creams that we can use, and those are the things that we want to promote for our patients, versus, a patient just using baby powder or cornstarch. Okay, those are some of the things that I've seen in the clinical setting. They use those things instead of a barrier cream. Okay? So, urinary continence care coordination and transition management. Okay? Home care. Because ultimately, we want our patients home. We don't want them, they're not going to be in the hospital for management of urinary incontinence, right? Okay, they shouldn't be. Okay, they should be able to go to the grocery store, they should be able to go to church, they should be going to their grandkids' ball games, they should be traveling on vacation and living their life even though they have urinary incontinence. Okay, so what are the things that are going to be important for them to manage at home? What do you need to teach them about? Okay, Kiana already said lose weight. Okay, so maintain a normal, healthy body weight. What else?
Avoid vigorous exercises.
Okay.
That's what
Let's say I had a surgical procedure. Okay, I had the sling. Is there anything post-operatively that I need to be taught about?
Sexual intercourse.
Sexual intercourse. Okay. I had my sling procedure. Can I have sex within 24 hours? No. How long do I need to wait?
6 weeks.
6 weeks. And I should have a follow-up appointment and be cleared for that. Okay. Do I want to hop right in a swimming pool, lake, hot tub? No, why? Bacteria. Okay, so I want to shower and kind of limit my baths where I'm submerged. Okay, especially if it is a public entity. Okay, what else?
Instruct them not to insert anything into themselves.
Yes. Okay, so if I am still having periods, okay, I don't want to use tampons during this post-op period. What else? Is nutrition important? Okay, so we still need to talk about what is healthy for me to eat. I still want to avoid the alcohol, the caffeine, the high acids. The best thing for me to drink is water. What else?
Avoid my strenuous exercise post-op.
Uh-huh. When should I see somebody? If I start to have fever, pain, abdominal cramping, discharge, do I wait 6 weeks to my follow-up appointment? No. Okay, so if I start to experience fever, chills, abdominal pain, cramping, discharge, bloody discharge, okay? So when we're looking at this home care, self-management, our healthcare resources, okay, we need to think about what do we tell our patient, okay, to maintain their health? What do we tell our patient is abnormal and they need to come back and seek help? Okay, because a lot of times, if patients aren't told specifically, what happens? They just wait. Oh, well, I thought it was normal. Okay, what else? That Q2-hour voiding, changing their appliance, they're still dribbling. All of those things, okay, to promote their health. Okay. And, you know, if a patient has surgery, they must keep their follow-up appointment. Okay, I have a pretty iron stomach, okay, but we had a case come in that, you guys, I couldn't believe it. I absolutely couldn't believe it. A woman had a sling procedure and had a sponge in post-op that she was supposed to return in, like 24 to 48 hours and have that removed. Okay, it was on her discharge instructions. She had an appointment for her to come back in and have that removed. She didn't. Okay, she came to us weeks later complaining of abdominal pain, vaginal odor, and a vaginal discharge. Okay, it was not until upon examination that we realized, oh my gosh, here is the sponge inside this woman. Okay, nasty. Nasty, nasty, nasty. Okay, it was by far one of the ickiest things I've ever seen. Okay, biohazard, got her on antibiotics, got her all cleared up, sent her on her way. I kid you not, a couple of days later she called back asking if we had saved that because she was thinking about filing a lawsuit. And I was like, well, no, we don't save those types of things. But by the way, you didn't follow your discharge instructions. Okay, you wouldn't have been at this point if you had followed your discharge instructions. Okay, so when they're doing this home care and management, okay, we need to make sure that their instructions are clearly written down, okay, that their appointments are made, that they understand what their responsibility is in following up with those discharge instructions. Okay, do not just hand them a piece of paper with their discharge instructions and say, here are your discharge instructions. Okay, because they may not understand them. Okay, they may not understand how to take their medicine. Okay, if it's an antibiotic. Okay, they may not understand that they should not use a douche. Okay, or anything like that. Questions? Okay, so how are we going to measure our outcome? All right, we want them to either not have any episodes of urinary incontinence, or we want those number of episodes to decrease. Okay, that's our goal. We want to maintain tissue integrity of the skin, the mucous membranes. Okay, we want to demonstrate knowledge of proper use of drugs, correct procedure for SelfCap, use of the artificial sphincter, or care of an indwelling urinary catheter. Okay, and this is hugely important. The SelfCap and indwelling catheter. Okay, so if I have to SelfCap, what's the number one thing I need to remember? Technique. Technique. Okay, because a lot of times what we see, patients try to reuse catheters. And I see it in patients with urinary incontinence, and especially our spinal cord injury patients. They try to make their stash last. Okay? Should be a one-time use on their straight pads. Okay. They should not wash them in soap and water and hang them back up to dry. Okay. That is not sterilization. Okay? What about an indwelling catheter? What do we need to teach them? Foley care. Okay, so what does that entail? Okay, I've never had a Foley catheter before. So what would you teach me? How am I going to take care of that? What are things that you have to do as a provider to care for my Foley that I need to know if I'm going to manage it at home? Empty the bag. How often? Do I wait till it gets full? How often should I empty it? A half or a third. Okay, and we could say, 4 times a day. At least empty it 4 times a day. Okay, what about cleaning? Is that important? So is there any special technique that needs to be used in cleaning an indwelling Foley catheter?
Is it the CSG? Like, do they do that? Or is it only in hospitals? Like, cleaning it with the CSG?
With the chlorhexidine?
Mm-hmm.
So usually in the hospital, okay? But when I am cleaning, okay, is there a certain way that I should be cleaning the Foley catheter itself? Away, down and away, okay? We don't want to start at the kind of the distal part of the catheter and clean towards up to the vagina or up towards the urinary meatus of a male. Okay? So we want to use all of those same precautions that we're taught. We need to demonstrate that to the patient. And we need to make sure that that patient can demonstrate their care. Okay? Because we can't just give them a handout or tell them you need to perform peri-care, okay, 3 times a day. Right? Because they're not going to know what peri-care means. Okay? We need to go through it with them, show them, okay? Because what's going to happen? we're going to identify any lapses in their education and their understanding of that procedure. Okay. We may experience a patient who says, I'm not doing that. I'm not going to touch myself there. So then who's going to do it? Somebody has to, right? So it may be a significant other, husband, wife, girlfriend, mom, dad. Okay. Or if they can't manage it, then we have to find someone that can. Okay? Because when we start talking about different devices, whether it is a Foley catheter, an ostomy, an ileostomy, any of those types of things, patients can say, I'm not ready to do that. I can't take care of that. Okay? So we have to understand their willingness and their knowledge level, and then can they physically do it? Okay? So if I'm a 70-year-old female with severe Parkinson's, and I've got horrible tremors, is that something that I may need assistance with? Okay. I may not be able to SelfCap myself, okay, because of my other conditions. Okay, so we always want them to demonstrate to us. We want to explain it, demonstrate it to them, but we want a return demonstration of their knowledge and understanding. That way we can truly evaluate what they can and cannot do. Okay, then we want to demonstrate effective use of selected exercises of their bladder training program. So their Kegels, if they're using home therapy, the Q2-hour voiding. Okay, and a lot of times we have them keep a voiding schedule. So they'll tell us, I voided at 12:30 and it was 150 mils. Okay, and then select and use incontinent interventions devices and products. Okay, because sometimes, just like when we're doing laundry. Okay, you have a certain type of laundry or a certain brand of clothes or socks or undergarments that you like to wear, right? Okay, well, it's the same if I'm going to have to find a product and a device that I'm going to use from now till forever. Okay, and I may have to try a couple of different types of devices and appliances before I find one that fits my body well, that meets my demands. Maybe I'm a exercise instructor, and now I have stress incontinence that anytime I physically exercise, I leak. So I exercise a lot, I have a lot of fluid intake, so I need a device that is going to hold up to my leakage. Okay, I may have to try a couple of different products. Okay? Questions on incontinence? Okay. So cystitis is something that we can get. It is an inflammatory condition of the bladder. Usually refers to inflammation from infection. Okay. So a lot of people don't say, oh, I have cystitis. What do they say? I have a bladder infection. Okay? Irritants can cause cystitis without infection. Okay? So what are you thinking of could be classified as irritants? What are some things? Sprays? Those lotions, potions, those types of things? Okay. The bath salts, there's all different types of bath bombs and scrubs and those types of things that you can put in a bath. Sometimes those can be very irritating. What else? Can you think of anything else? Intercourse? Sexually transmitted infections? What else? So there's all kinds of lotions and potions and things that can help with sexual intercourse and increasing sexual pleasure, those types of things. What else? What about just clothes? Okay. Because typically we want undergarments that are cotton or breathable fabric. Okay. And sometimes that cotton and breathable fabric aren't really cute, are they? Okay? So we have to look at, okay, what type of undergarments are our patients wearing? Okay. Are they wearing breathable fabrics? Okay. What else? What other irritants? Fabric, sexual intercourse. What else can be irritants?
Laundry detergent.
Detergents.
And then, like, your sponge story or tampons.
Body wash. Okay, so when we're assessing our patients and they come to us and they have irritation and inflammation, these are the types of questions that we need to ask. Okay, have you had regular sexual intercourse? Okay, and then we have to know, is that with one or multiple partners? Have you changed detergents? Have you changed the type of undergarments or gotten new undergarments? Are you using any type of vaginal sprays, creams, lotions, powders? Okay, and we talk a lot about these things with women, okay, but they can happen to men too. Okay? So, etiology and genetic risk. More than 80% of the UTIs are caused by E. coli. And how does that happen? Yeah, wiping the wrong way, poor hygiene. Okay, so we need to make sure that we are educating our patients on proper hygiene techniques. Okay, wiping front to back. Okay, and then catheters are the most common factor associated with new onset UTIs in the hospital and long-term settings. Okay, and that's abbreviated as a CAUTI, C-A-U-T-I. Okay, catheter-associated UTI. Right. And when we look at our national patient safety goals, this is one of them. Okay. Catheter-acquired infections are one of the things that when they pop up, okay, and the patient came into the hospital, they didn't have any signs and symptoms, they had surgery, we put a Foley catheter in, and then post-operatively they started to experience signs and symptoms. National Patient Safety Goals, Medicare, Medicaid, and insurance companies look at that as, did this patient receive substandard care? Because if they received standard care or above, proper technique would say that the likelihood of them having a UTI should have been eliminated. Okay. And they can come back and say, we're not paying for this hospitalization. Okay, which then turns around to dollars, because it's not just the treatment of the UTI, it's that whole hospital stay. They worry that that patient did not receive the standard of care that they should have. So maybe I've only been in the hospital for 24 hours, but maybe I've been in the hospital for 3 weeks or 6 weeks. That's a huge hit to a hospital, you guys. Okay, so that's why we don't see a lot of Foley catheters put in on the floor anymore. Where are most of our Foley catheters inserted now? Loud.
Surgery.
Surgery, yeah. In the OR, in a sterile environment. And then how long do they stay in? Until the surgery's over, and usually maybe the first 24 hours. If it goes beyond 24 hours, there needs to be justification written in the chart. Okay, so when you guys are in clinical, start looking at that. Okay, I have a post-op patient. Okay, do they already have an order for that Foley catheter to BDC in 24 to 48 hours? Okay, because a lot of them will. Okay, and then the interstitial cystitis. Okay, the internal cystitis. Okay, the incidence of a UTI is only second to an upper respiratory infection in primary care. So the number one reason a person sees somebody in primary care is an upper respiratory infection. The number two reason is a urinary tract infection. And then it is the most common healthcare associated infection. Okay, a lot of people think it's a hospital acquired pneumonia. And it's not. It's a urinary tract infection. So how do we prevent and maintain? Okay, number one is sterile technique. Okay, so important that when we're putting that Foley catheter in, okay, that we have sterile technique. And like I demoed, okay, when you guys are practicing, okay, use that eagle eye, okay, because we don't want to make a person sicker than what they already are in the hospital. Okay, and we know that especially with our elders, okay, they can become septic very quickly from a UTI. And they may or may not survive. Okay, and we don't want that to happen. Clean technique when using the intermittent catheters at home. Okay, single-use catheters recommended for home. Okay, that's what I was talking about. Okay, I can't tell you the number of patients we have seen over the years, especially your spinal cord injury patients, that try to stretch their supplies. And then they end up with sepsis because they have infected themselves by using a dirty catheter. Okay. The NPSG is the National Patient Safety Goal. Okay, and that's the CAUTI prevention, the catheter-acquired UTI or catheter-associated. Okay. And then we want to promote liberal intake of water. Okay, about 2 liters a day. Okay, is what we should be taking in. Okay, and then avoiding the caffeine, the alcohol, those acids and irritants. So the cues that we're going to assess for. Okay, when a patient comes in, they'll have reports of urinary frequency, dysuria, and urgency. Okay. We may also see fever, chills, and nausea, and that's going to indicate infection. Okay. So with irritants, we'll see frequency, dysuria, and urgency. Okay, we want to assess their catheter. Okay, have them void for a urinary examination. So we want to collect, okay, a urine sample. Okay, and your book talks about a clean catch, and I actually think that is in the first chapter, maybe. It is on page 1314. Okay. It talks about how you collect a clean catch, a catheterized specimen, and a 24-hour urine collection. Okay. So just make sure that you're familiar with that. Okay. A lot of times patients think we have to have, this whole big sample. We actually only need like 30 mils. Okay, an ounce for a urine specimen. Okay? We're going to look at vital signs. We're going to assess their lower abdomen, and we're going to palpate their bladder. Okay? We're going to palpate their bladder for any tenderness, fullness. And when we're assessing a patient, okay, one of the determinants of a upper urinary tract infection, okay, or lower urinary tract infection. Lower meaning bladder, upper meaning kidneys, okay, pyelonephritis, okay. With cystitis or a lower urinary tract infection, they're typically going to have pain in their lower abdomen, okay. They may complain of some bladder spasms, abdominal pain, okay. Versus if that infection has gone up to my kidneys, I'm going to complain of low back pain or pain right lower than my ribs. Okay? And we call that costovertebral tenderness, CVT. Okay, so they may say my back hurts really bad. Okay? And one of the things that we can do to determine that, okay, is have them sit up or lay on their side, okay, and you're just going to kind of make a fist and tap, okay. If we tap and they have excruciating pain, that is positive costovertebral tenderness, okay, kidney pain, okay. So kidney pain in the low back, okay, bladder pain, lower abdomen, okay. And sometimes they may have infection so severe that it hurts both places, okay? And they can also be throwing up, okay? They'll be really nauseated, vomiting as well. Okay, so what do we have to do, right? We want to get that clean catch urine, okay? So it's important for us to then say, okay, well, what do I got to do for that clean catch urine? Okay, so then we go to our page. Back in chapter 60, that tells me, what am I going to do? Okay? They're going to have those 3 wipes. Okay? That the first 2 wipes, okay, are going to wipe on each side, and then the third stroke is going to be right down the middle. So side, down, just like we would clean during a catheter insertion. Okay? And then on the male, okay, they're going to use the 3 sponges and they're going to wipe down, okay, the head of the penis. Okay. The big thing to tell them is when they are voiding, okay, that cup at no point should touch any anatomical structure of their body. Okay, so the top ring inside of the cup, they shouldn't touch the inside of it. They should only touch the outside. And then ensure the patient understands the cleaning. Okay, because a lot of times what do? We send them with the cup into the bathroom with the 3 swabs. Okay, but the big thing is that nothing should touch the inside of the cup. And I don't have a specimen cup up here, but like sometimes people will take the lids off and they'll hold the cup with their thumb inside the cup rather than on the outside. Okay, and then they've contaminated the inside of the cup. Okay, so we're going to send that for our urinalysis and then also our culture and sensitivity. And what did we say that the culture and sensitivity was for? Yeah, it's going to tell us what type of bacteria so we know how to treat it. And then the serum WBC with differential. What's the serum WBC going to tell us? Infection. Am I dealing with a systemic infection now? And then other things, pelvic ultrasound or a CT may be needed. The voiding urethrography, and then I can't say that word very well today, and then a cystoscope. Okay, so they will actually take a camera up through the ureters, looking to see what type of structures are there. Are there polyps? Is there a mass? What's going on? Okay. And then our action. Okay, non-surgical management. Okay, drug therapy. Okay, NSAIDs, Tylenol. Okay, now, depending on infection or not, I may be on an antibiotic. Okay, there's also antiseptics, antispasmodics. I want to increase my fluid intake. Okay, remember, at least about 2 liters a day. And then comfort measures. Okay, what kind of comfort measures can you think of? If I have a bladder infection, what might make it feel better? What?
heating pad.
A heating pad, okay, because you can have abdominal pain and spasms. What else? Tylenol. What else? Can you think of anything else? A sitz bath, yes. So what's a sitz bath? Didn't we say baths were bad? What's a sitz bath?
Set in the toilet, like your 90 volt in the bag, water, mixed drinks out, and then flushes.
Okay, so that's one way. Sometimes they'll use an IV of normal saline, okay, and it's just used as irrigation, okay. But a lot of times what we see, especially for OBGYN cases, it's a little squirt bottle, okay, that you fill with warm water, okay, and when the patient goes to the bathroom or if they're experiencing a lot of itching and burning, they fill their bottle with water, they sit on the toilet, and then they just use that as kind of an irrigation or a flush to that area, okay, and that's a sitz bath. Okay, now, there are some very fancy high-dollar toilet commodes that have that feature built in, kind of like the self-cleansing toilets, okay? See them a lot in Europe, actually, okay? So, those are some of the comfort measures. Okay, now, we don't want them sitting in hot tubs. Okay, we don't want them sitting in the bathtub soaking. Okay, why? Bacteria. Yeah, we don't want to do that. Okay? And then surgical management is going to be anything that helps to treat the deformity. So maybe I am at risk for UTIs because I've got a structural anomaly. Maybe I have stones, and that's causing the backup of stagnant urine. Okay? So care coordination and transition. Okay? We started off with this, okay, assessing that patient's level of understanding, and that's how we have to kind of close that loop. Assess the level of understanding for the client. Okay? We want to make sure that they're going to take all of their prescribed medication. Okay? This is one of those cases where patients a lot of times will take the medicine until they feel better. And then, my infection must be gone, and they stop taking their medicine. Okay? They really need to complete that full course of therapy, so 7 to 10 days of PO antibiotics. Cipro, Bactrim are very common. Okay? Then they need to come back in and provide us with another clean catch so that we can make sure that that infection is gone. Otherwise, what happens? That infection comes back and it's more proliferate. It's kind of a bigger, badder version because it had some antibiotic. It didn't finish the course. It got used to that antibiotic, and now it is more of a superbug. Okay? So then we also want to make sure that we're addressing any concerns associated with intimacy and recurrent UTIs. Okay? So when we mentioned earlier, we want to ask the question, are you sexually active? Okay? And we can't put an age on that question. Okay? Because there are kids that are 9, 10, 11, and 12 years old who are sexually active. Okay? We can't assume that just because they're retired and they live in a skilled nursing facility that they are not sexually active. Okay? And I had a lady tell me one time, she said, well, honey, I'm old, but I'm not dead. Okay? All right? They still have desires. They still have the need to have sexual intercourse and loving and belonging. Okay? So we can't eliminate any age group. Okay? So we need to talk about those. Okay? Especially if we have someone who is having recurrent infections, we have to have those discussions. Are you having multiple partners? Because this could be related to a sexually transmitted infection. Okay, and if that's the case, then this person, our patient, as well as any of their partners, need to be notified and treated for that sexually transmitted infection, regardless of what it is. Okay? And there's that, there's a movie, like The Other Woman, where it's got Cameron Diaz in it, and she's fallen in love with this guy, but he's married. And these three, they find out that there was actually even a third woman that is involved in this kind of twisted thing. And they come up with this plan to tell him, oh, well, I have chlamydia, and then that way he won't have sex with me. And he goes home. The one tells him, oh, I have chlamydia. You're going to need this prescription. Go see your doctor. Then he comes home to his wife and says, I've had this cough, and the doctor told me that you should take this Z-Pak too. And that's kind of, when I saw that in a movie, I thought, well, haven't we gone kind of astray in our society that we can almost not poke fun at, but in a way it was poking fun at sexually transmitted diseases and just kind of, oh, by the way, let's go ahead and you need to have this treatment too. Okay? But those are discussions that you have to have with patients. Okay? Because your patient may be a happily married person, but has had extracurricular activity on the side and may not want to tell the spouse that there is a sexually transmitted disease, because then that's going to open up that I've been unfaithful. Okay? Or we've got a 12-year-old, okay, that doesn't want mom and dad to know that she's sexually active or that he is sexually active. Okay? So we have to have those discussions, and sometimes they're very uncomfortable. Okay? Questions on cystitis? Okay, so then we get to urethritis. Okay, inflammation of the urethra, highest incidence in adults ages 20 to 24. Sexually transmitted infection is the most common cause. Symptoms include mucopurulent or purulent discharge, dysuria, and discomfort. Okay, and then interprofessional care. Your analysis is going to show pyuria. We're going to do all the tests for sexually transmitted infections. It will usually resolve spontaneously unless there is an STI detected. So a sexually transmitted infection then warrants treatment of all parties with an antibiotic. Okay? Now remember that some of the sexually transmitted diseases, once you have them, you have them. Okay? Herpes. Okay? Herpes simplex. You can have herpes simplex virus 1 or 2. Okay? Oral or genital herpes. Okay? That virus can be spread either way. Okay? The only way to detect which type of virus it is through blood tests. Okay? The patient will have periods where maybe they don't have a breakout. Okay? And with herpes, you'll have a lesion, like an oral lesion, okay, like a big cold sore. Okay, it'll ooze. That same thing happens, okay, in genital herpes. Okay, only we see what are called kissing lesions. Okay, so on a woman, if I have a lesion on one side of the labia and the labia touches the other side, a mirror lesion will start to appear. Okay, and those are called kissing lesions. Okay, they are painful ulcerations that will ooze and need to be treated. Okay, so Virex, a lot of your antivirals. Valtrex is another commonly used medication to treat it. Some patients will only take it like during an outbreak, but other patients will take it every day as a preventative, as a prophylactic. Okay? one of the things that you have to remember is, even though I don't have an outbreak, I still carry it. Okay, so I could make someone else have an outbreak, even though I don't have an outbreak. Okay, you're typically going to spread it when there is an open lesion. Okay, that fluid, the vesical fluid, then transfers to the other person, and then that's where that sexual transmitted disease component comes in. Okay, but just because you don't have active lesions doesn't mean that you are still not a carrier. Okay, once you have the herpes simplex virus, you have the herpes simplex virus. Okay, did you need something, Darryl?
I'm just ready to take a break.
Okay, well, let's take a break. And then we'll talk about urolithasis.
Oh.